back, everyone. Great to have you back on the channel, Einstein's Eyes, our YouTube channel. I'm Carl Rosen, oculoplastic neuro-ophthalmology, Anchorage, Alaska. Fellowship trained, and my partner and co-resident back at Albert Einstein in the good old days, Jon Ditkoff.
Hello, everyone. I'm coming to you from Northern New Jersey, where I've been in practice for 30 years. I'm a cornea specialist who also does general ophthalmology.
Right.
And it's nice to see Carl. Our spring is starting, whereas I think he's probably got a few more months in Alaska of winter.
It's brutal, John. It's brutal. But
Sorry.
Alaska does have a special energy. I have to admit it. Growing up in New York, you have to appreciate the mountains. So that's what I do have here. And, you know, when you get married and your wife lives in Alaska, you gotta go with where your wife is. So guys, back to healthcare and ophthalmology, as our channel relates to these subject matters and topics. Today, we're going to talk about amniotic membrane, which is an interesting topic. It's a device that ophthalmologists use and other medical specialties, but ophthalmology in particular for corneal surface problems and conjunctival surface problems. But Jon is going to discuss this as a cornea expert, a fellowship-trained cornea expert. And Jon, I'm looking forward to your comments, experiences, and what you have to say.
Great. So membrane is part of the placenta. So it's a layer of the placenta. And it's pretty interesting because the placenta, as we all know, nourishes the baby. It's how the mother nourishes the baby in utero. And when a woman delivers the baby, the hospital, and I don't really know the details on this, but they basically ask her permission to take part of this tissue. And it's sent to various labs where it's used. For me as an ophthalmologist, it goes to the eye bank. And once it's there, they take this tissue, they cut it into small pieces. They obviously evaluate it. They screen it for any known diseases. And once they know they can use it, it's cut into pieces, almost looks like contact lenses. And that tissue is put in a little box, sterile, and it's sent to ophthalmologists like me who use it pretty commonly. So what's really amazing about this tissue is, as I mentioned, it's baby tissue. So it has growth factors, stem cells, regenerative properties. There's have shown that it can regrow nerve tissue. It's antibacterial, so it's even helpful for infections that are not responding to typical medication. So many different corneal conditions. When I go back in my career, 20, 30 years, what I used to do is I used to take this tissue, and it was really good as an anti-inflammatory tissue. So after I did surgery on someone, like a pterygium surgery, I was removing a growth, I might take that tissue and stitch it into the eye. There were also patients that had healing problems, and I would take it and stitch it into the eye. And that was many years ago, and it was not easy procedures. I mean, these were complicated procedures that took a long time to put very small stitches in. In the last 10 years, it's really been exciting because now this tissue doesn't have to be stitched in. We get it, as I said, it looks like a little piece of a contact lens. I have a picture of it.
Yeah,
first
actually, yeah, Jon, let me show you
that's
that.
being put on the eye.
Yeah, let me show you that picture, okay?
Yeah.
So, yeah, what you're talking about, correct?
I see it yet. Oh, now I see it. Yes. So that's a very enlarged version, but just imagine it looks almost like a contact lens. And if I have a patient that has a host of problems, so for example, a corneal ulcer that's not healing, we are giving them antibiotics. Maybe they're even responding, but there's still a lot of inflammation. I love the idea of placing this tissue right over the ulcer, and it regenerates tissue. It's used to burn patients, just to give you an example, where their skin isn't healing. What I do is I can place that tissue, and what it does is it regenerates the outer surface of the cornea, which is really important because the outer surface of the cornea helps vision, but it also helps the shape of the eye and a lot of problems. So for example, there's a condition called neurotrophic keratitis, very common. Neurotrophic keratitis can occur in someone who's been a chronic contact lens wearer. It can occur after infections such as herpes simplex or herpes zoster, as well as other degenerative conditions that degenerate the nerve tissue. And if that nerve tissue is damaged, very, very problematic for those patients, because what happens is the nerve is responsible to protect the cornea. So if someone's eye, for example, is inflamed or dry, the nerve's job is to stimulate healing, and the nerve's job is to stimulate tear production. So in people that have neurotrophic keratitis, they actually have decreased reflexive tear production and decreased healing. So now you can show this picture, Carl. Right. So getting back to why we do this. So for example, neurotrophic keratitis. That's a good example. So I have a patient, for example, that's just not healing well, and they have constant inflammation and irritation and transient blurred vision, because what happens is the cornea needs to be smooth and lubricated. So what I do is I place the amnion, kind of like what this picture is showing. Now, this is a very large piece that's about the size of a contact lens or even smaller. And I just place it on the cornea right in the office. So for my patients out there and for anyone interested, it's a really simple procedure. Person comes in the office, and what I do is I have them sit back on the exam chair after I put numbing drops in their eyes. Once the eye is numb, I put a speculum in the eye that keeps it open. So you can actually see, I don't know if you guys see that, but it's helping to keep the eye open. And I let the eye stay open for a minute or two in order for the cornea to dry out. Once I know that it's dry, I can put the amnion and I just place it right on the cornea. It's not invasive. There's no stitches. I just place it on the surface and I wait. And once it's on the surface, it actually adheres, sticks onto the cornea so that it's really stuck on. And once it's stuck on, I know that it's going to start to absorb. So once it absorbs, it becomes part of the cornea. So that person gets the benefit of this baby tissue of being absorbed into their cornea. To help it along, what I also do is I'll put a contact lens on the eye at the end of the procedure. The contact lens is helpful because sometimes that piece of tissue will move a little bit, or actually dehisce, which means it doesn't stay adherent. It kind of falls off from rubbing and removing it. So I leave the contact lens on for a few days, maybe 3, 4, 5 days, depending on the condition we're treating, sometimes even longer. And during that time period, the person comes back to me, the amnion's already absorbed, so we won't even see it. And then I just take the contact lens out. The procedure itself takes no more than 10 minutes. It doesn't hurt. The person can leave that office that day being able to drive. They can do things normally. I did this recently on a dentist who went right to work and he saw patients all day. So it's not something that's debilitating. In terms of risks, it's a minimal, if any. The biggest risk is really 2 issues. One is we're leaving the contact lens on the eye overnight. So there's a small risk of infection from the contact lens, not the procedure. So very simple. I put all my patients on antibiotic eye drops that they take 4 times a day. And by doing that, they essentially eliminate the risk of infection. And then the second thing that does happen occasionally to patients is they just don't like the contact lens. So I'll get a phone call sometimes 2 days later instead of 3 or 4 days later. And the person says, you know, my eye's starting to get red, a little bit irritated. We just have them come in and we take the contact out. Most of them, by that point, the amnion's already absorbed. So it's not a big deal procedure. It's actually very safe. It's covered by insurance companies for specific diagnoses. So for example, neurotrophic keratitis, non-healing ulcer. I've done it for band keratopathy, which is when calcium starts to deposit on the surface of the cornea, making it very irregular. What I can do is to help heal that cornea, I do the amnion, which comes on top of it. It doesn't necessarily remove calcium. You have to remove the calcium mechanically, but it decreases the likelihood of more calcium deposition. Also, a big condition that I take care of is a condition called basement membrane dystrophy. That's a fancy way of saying that the cornea is just not smooth. It's irregular, it's lumpy, bumpy. So this is a wonderful procedure for those patients because some of those people, it progresses to the point where they actually have decreased vision, foreign body sensation, transient blurred vision, feeling like their eyes irritated, inflamed. And if we get to it before it gets to that part where it's really lumpy, we can halt the progression of the condition and smooth out the cornea. And that's what this does. It's basically like filling in those irregular areas to smooth it out.
Potholes.
Pretty cool, right, Carl?
Yeah.
You're ready to be a cornea guy now, right?
I think those days are over, my friend. But John, great talk. So I think our audience understands a little bit more about amniotic membrane use, indications for those folks who are in need of such a procedure. Great topic. And Thank you, John, for that. We're gonna continue our topics in healthcare, ophthalmology, policy, innovation, technology, finance-related issues in healthcare. So we're starting to branch out. We like it. I think the audience likes it. So we're gonna continue. But appreciate it, guys. We'll see you on the next one.